record.
Okay, great. Hello, everyone. My name is Ray Davis. I am one of the Pediatric Hematology-Oncology physicians at ECU, and I am happy to be talking to you guys today about women with bleeding disorders. My next button does not work. Oh, there we go. So we're going to talk about both the reasons that there is a disparity of healthcare for women with bleeding disorders and how that plays into women's experience, as well as talk about a few of the key differences in being able to recognize and diagnose bleeding disorders, as well as gain a little bit of knowledge about treatment options for the most common bleeding symptom for women, which is the menstrual cycle. And I will tell you that as a pediatrician, my, I guess the lens I view these things through is really through pediatric, and so adolescent and young women. However, everything I'm talking about is applicable to older women with maybe just a few more options for older women, which I can discuss. So the big elephant in the room, I really like this quote, let's de-vilify the word bias. And so rather than, us talking, getting all angry about biases against women, we need to recognize that we all have various implicit biases from cultural messages that, we've received our whole lives. Every single person has this. And until we can recognize that and face it, we're never going to be able to move forward. And so really wanting to try to create a healthy, safe space to talk about these things, acknowledge these things, and be able to move forward. So the first thing I wanted to emphasize is being very careful about the words that we use. So the words that we use don't necessarily, their meaning is not just about like the Webster's dictionary definition of the word. Every word has different historical context, it evokes emotion, there's unwritten ideas behind a word. And I think we need to be careful about that in terms of our language around bleeding disorders and women with bleeding disorders. For instance, we hear the word hemophilia. I know Laura Joyner in our very first lecture this morning mentioned that, hemophilia, our perception is boys with hemophilia A or B. And so that perception of males being the ones with hemophilia already puts a barrier up to people perceiving bleeding issues in women as a problem. So the fact is that hemophilia encompasses more than just our classic hemophilia A or B. Hemophilia technically is any tendency to bleed for whatever reason. So really consider saying bleeding disorder instead of hemophilia. You may see the abbreviation WBD in here, which is women with bleeding disorders, or WGBD, women and girls with bleeding disorders. Another word that we use is symptomatic carrier. And down here is a famous star that I know is a carrier and has done a lot of great advocacy work for women with carrier status. So the perception when you say carrier is someone who doesn't really have the disease. And so a symptomatic carrier, well, maybe you bruise a little bit more, maybe you ooze a little bit more. It's not really a problem. But the fact is that a symptomatic carrier is someone who has clinically significant bleeding symptoms. And so really would be more appropriate for us to say woman with hemophilia, to sort of take down that barrier of already perceiving them as not really having a disease. This disparity has been present really from the beginning of our understanding of bleeding disorders. So the first recognition of bleeding disorders was in 1803. Of course, I know everyone talking about bleeding disorders knows Queen Victoria, but again, the way we talk about her is this woman without any bleeding issues who, passed on this disease throughout Europe. So there's always been a higher burden placed on women regarding bleeding disorders. In fact, in the actual medical journals, the language very much reflected that, saying that females hand down the disease while males are the victims of it. So from the very beginning of our understanding of this, there's been that additional barrier in that bias towards women. So let's just do a little bit of myth busting in regards to hemophilia A and B. The reality is that 50% of women who are carriers, who are heterozygous for hemophilia A, have factor levels that are less than 50%. They can be categorized as having mild hemophilia. What that means is that, a male with a factor level of 37% very easily has the diagnosis of mild hemophilia. He would be offered factor to treat bleeds, would have bleeding plans accordingly. Whereas a woman with a factor level of 37%, well, she's a symptomatic carrier. The end. So we really need to change this understanding. The other thing that we're recognizing is that women with a factor activity of 40 to 60%, in other words, in the low normal range, have a significantly higher bleeding scores than those with greater than 60%. So even if you have what's classically considered normal factor levels, you can still have clinically significant bleeding that can impact your life. And for another way to look at this is beyond just hemophilia A and B, with von Willebrand disease, the average age of the first bleeding symptom is 6 years old for women. So we're experiencing bleeding symptoms from a very young age. However, the average time from the first bleeding symptom to receiving a diagnosis is 16 years. Significantly longer than for our male counterparts. So I really liked this specific article because it highlighted a few cases sort of emphasizing the real impact this can have on women. So the first patient presented to this HTC at around 50 years old. She was diagnosed as a carrier for hemophilia A when she was 29. So you see how many years she had had that diagnosis before she ever presented to an HTC. She was found to have a factor level of 37%. She had had heavy menstrual bleeding since she started her periods, lasting up to 2 weeks, causing iron deficiency anemia. She had postpartum bleeding, very severe sprains with mild injuries, and post-surgical bleeding. Her mother, 76-year-old, factor level 47%, had had heavy menstrual bleeding, postpartum hemorrhage requiring a transfusion, a left knee replacement that had bleeding so severe she required an amputation, and then ongoing joint swelling issues. The first patient's daughter, 21 years old, had a factor level of 56%. At a young age, she had bruising so severe that they had to undergo a child protective service child abuse evaluation. She also had heavy menstrual bleeding, joint swelling with injury. She had to have a second surgery after an appendectomy because of bleeding. And she had hip bleeds so significant, she needed multiple surgeries to take care of it. And then another daughter in the same family, 17 years old, factor level of 45%, had heavy menstrual bleeding, nose bleeds, bleeding issues with dental procedures. So you can see, we have a range of factor levels here that are all kind of in that, maybe mild, may even be classified as normal, yet they've had very significant symptoms that have impacted their life. And you see it took generations for them to be able to present to an HTC. So the World Federation of Hemophilia really is emphasizing that symptomatic carriers with low clotting factor levels be categorized as having hemophilia of appropriate severity and managed accordingly. And that disparity, though, is continuing today. I think it's easy to say, oh, we've moved on so much, our society is so much more aware of these things, and yes, that's true, but we're still not there. It's still stigmatized. It's still, women are classified as different. So there's a longer time to diagnosis. They're less likely to receive treatment. There's greater barriers to treatment. A lot of women report not receiving adequate education about their disease, about treatment options, not feeling empowered to make the best decisions for their health care. There's numerous social pressures. There's avoidance of social activities, there's missed school and work, covering bruises, even down to clothing choice, like, oh, I can't wear these pants today because I'm on my period and I might bleed through and I have to have, these things with me at all times in case I bleed. It can be a significant burden on a woman's life. And up to 80% of women with a bleeding disorder say that their bleeding disorder prevented sports participation, which is very sad, because while yes, there are some more high-risk activities, we really want to empower people to live as normal of a life as possible. And our question as providers should be, okay, this is, the risks of the decision you want to make. I recognize there may be benefits, so how can we help you do this as safe as you can? But that's not really an option that's being presented. This was a wonderful, wonderful article that our physical therapist, Laura Joyner, found and sent on to us. It's on von Willebrand disorder, but they said some very important things that I think are applicable to all bleeding disorders. So von Willebrand is primarily a disease of females. We're now increasingly learning how sex bias may have unwillingly affected patients' care in many areas. There seems to be a parallel between the increasing number of female hematologists and the greater recognition of significant von Willebrand disorder associated morbidities, especially when related to women's reproductive health. I think that is a very, very significant statement, which also brings us to the sort of other elephant in the room, which is for a lot of women, yes, there's joint bleeds and surgical bleeds, but women bleed every month. We have a bleeding challenge built into our very biology. And that usually ends up being the thing that brings women to diagnosis, and also the thing that has the most impact on their day-to-day life. So menstrual cycles can have a very significant impact on quality of life. Even though we are not living in a society where there are actual restrictions on women, you think about medieval societies where women had to be sequestered. However, there's still restriction when we're dealing with periods. It changes how we stand, how we sit, the clothes that we wear, what's in the forefront of our mind. So it still can have a very restricting feeling on someone's quality of life. There's also social stigma that continues to this day. So, we kind of laugh at some of these older period product ads, thinking like, oh, this product is so good, you can wear white. And even, back in the 80s, it was all, it needs to be discreet, heaven forbid someone know you're on your period, you must hide it. And even into the 90s, it was all about, we have to hide this, no one has to know. And again, you may think, well, oh, we're moving so far. However, even in the 2000s, we're still having, the women in white. In 2005, this ad, it was so important that no one know you're on your period, that they designed it to look like a candy bar. I mean, this is just, crazy. And so one of the more recent ads, yes, we've got some more color. Yes, that seems so much better. However, they're still advertising, discreet. Now we've got it so that the wrapper is so discreet that the woman in the stall next to you can't hear you unwrap it. These are the messages that women are receiving around their menstrual cycle, which is creating barriers both to women feeling comfortable in presenting these problems to providers, as well as providers being able to get that information out of patients because they're reluctant to talk about it. It's secret, it's forbidden. And a lot of women who may not recognize that this is heavy bleeding because they don't feel comfortable talking about it to other women. These cultural messages permeate society for decades. This old Midol ad is really it's just terrible. I just can't even. And some of these myths, I had to dispel this myth with a patient instead of tampons, it was an IUD last week. These things are still in our society. It wasn't until 1985 that the word period was even on TV. Yes, that is a pre-Monica Courtney Cox, gets the designation as first woman to say period on TV. Go Courtney Cox. But still today, our menstrual product ads, we have this mystery blue liquid, like all the blood and violence on TV and movies that we put out there without a thought, and yet menstrual blood is too offensive. Still to this day, men are terrified of menstruation. Like I said, myths are still being perpetuated to this day. Women's symptoms are being dismissed. You know, it's just a period. What's the big deal? And their symptoms belittled. Even last year, there was a tampon ad that was banned in the UK for having too much information about how to use a tampon. This was last year. So this is still out there in the community. And like I said, does have barriers to women feeling comfortable presenting these symptoms, as well as those symptoms being taken seriously and being treated appropriately. So heavy menstrual bleeding, you know, how do we diagnose it? So we have the three mainstays of bleeding lasting greater than 7 days, needing to change sanitary products more frequently, and passing clots. However, there's a lot of nuance here. First of all, a lot of people don't even really understand where the blood comes from. So you have here the endometrial lining. So during the first part of your cycle is when the endometrium builds up. I describe the endometrium as being sort of like fetus food. Okay, we're making this nice, nutritious little bed for a fetus to come and embed. Well, all of that tissue needs blood supply. And so as that proliferates, then you have the blood supply coming up. Well, when there's no pregnancy, then your body sheds that lining. So that's actual endometrial tissue that's part of what you're shedding. So some clots are normal. Some small clots are normal because some of that is also, tissue. Not everything is blood. And then of course, shedding that tissue then exposes those blood vessels that begin to shrivel. But for someone with a bleeding disorder who doesn't have the ability to clot very well, that bleeding may go on for too long before those vessels shrivel down. And bleeding lasting greater than 7 days. So a normal cycle is 2 to 7 days. Some key questions that I like to throw in there to help with diagnosis is, are all days the same heaviness? So typically with a menstrual cycle, you have some initially heavy days and then it kind of tapers off. However, women with a bleeding disorder tend to have every day is heavy, 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 stops. So that is a key sign. Also figuring out how far apart are cycles. So women with anovulatory cycles, for instance, women with PCOS, that proliferation phase continues. And so it's almost like you get multiple cycles of buildup before it sheds, meaning when you do have a period, it can be excessively heavy. In the first year after you first start your periods, irregularity is normal. However, we still have to recognize that even though it may be within the normal expected, it can still be significantly impacting these young girls' lives and making them miss school and having a social impact, and still deserves recognition and treatment. The need to change period products is one that I'm finding requires a lot of nuance. First of all, note that I say period products and not sanitary products. Again, saying sanitary products conveys the idea that this is dirty. So I like to use a different terminology. So, there's different things in there about, in the literature about what is normal, how many pads, how many tampons, but that gets tricky, as I'll show you in a minute. The key thing though is that we're very bad at figuring out how much blood we're losing. I have a fun time with students when I'm trying to educate them on this, and I ask, okay, how much blood do you lose during a normal period? Every time I get estimates much exceeding what actual blood loss is. And when I tell them, no, it's only about 30 or 40 milliliters, which is an ounce, most women look at me like, no, you're kidding me. It's got to be more than that. So it can be very tricky, getting the history and figuring out what really is heavy bleeding, just because it's difficult to know. It's not like we're sitting there measuring it with a measuring cup, okay? And so it's actually twice the normal amount. That is when you start getting more heavily associated with things like anemia. You also need to get into the reasons that girls change, especially in the adolescent population. I hear not infrequently, oh yeah, I have to change my pad every 2 hours. But then I find out, well, they are changing every time they go to the bathroom because it's gross, it's not sanitary. And so these pads are not saturated. And so yes, you're changing every 2 hours, but that's very different than needing to change every 2 hours. And some are just afraid. Again, some are told they have to for hygienic reasons. So you've really got to dig down into that. Accidents, you also have to kind of figure out, okay, are the accidents, anytime versus, well, if they're only overnight, is this because of the period product that you're using? Is it's, something else going on here? So there's still a lot of nuance here. The other thing complicating the picture is the range of period products available. They're not all created equal. Just as a little comparison here, a panty liner is only 5 milliliters, whereas your ultra overnight super big can hold up to 10 to 15 milliliters. Again, your slim tampons and your ultra tampons about the same range. So when you're taking that history, it's like, okay, are we using 6 slim tampons or are we using 6 ultra tampons? Those are 2 very different things. And we also have a lot of newer period products, which aren't actually new, but they're becoming new in cultural acceptance. For instance, the menstrual cup, it can hold 25 to 30 milliliters, but people are usually going to empty it much sooner than that. Some of them, though, even have little lines on them that have, how many milliliters, so that, girls can actually measure more accurately how much they're bleeding. But it, involves different questioning. Period panties are a new thing that's out there, which is basically underwear that has an absorbent built-in lining that sort of replaces a pad, if you will. Those can hold up to 2 regular tampons. So if that's the product that they're using, we have to kind of rethink how we're asking these questions and rethink, well, what's too much and what's indicative of a bleeding disorder. The pictorial bleeding assessment chart is something that's very helpful. It's validated, it's wonderful, but it's also even more helpful, especially because of this variance that I've discussed in a woman repeating it after treatment, meaning it's very significant. You have a high score, we've initiated this treatment, now your score is reduced, versus your score didn't change that much. It's a very useful objective assessment of how well our treatment is working. But again, depending on what products they're using, you may have to do a little bit of education on, all right, if you're using period panties, then, if one is saturated, put a 2 here for this. So there still may need to be some education in it. This app, I actually just discovered this week, thanks to our wonderful nurse practitioner, Chelsea, who gave a lecture earlier. This app is put out by the Hemophilia Federation of America, and it's a very easy to use app that actually uses the pictorial assessment, so that when a girl is having her period every day, she can mark how many of each thing, and it does the score for you, and you can even put in different symptoms. And the wonderful thing about it is it looks like it can sync information with the Athens clinical manager, which is something that a lot of HTCs use as part of research and data collection, but is a wonderful way for patients to help communicate that to their physicians and to keep track of it. Some other historical considerations that I think are really important is family history, especially maternal history of heavy periods or postpartum hemorrhage. A lot of girls, determine what is normal based on the other women in the family. Well, if the other women in the family have an undiagnosed bleeding disorder, then everyone is thinking their heavy periods are normal. And so there's a lot of times that I get a young girl in and then I take the family history and I'm like, all right, mom, you need to get tested too. You may have this as well. And I even had a patient a couple of weeks ago with like every checkbox for concern for bleeding disorder. And I take, the maternal history and it's every checkbox of bleeding disorder. And, the girl's coming to me for anemia, not even concerned for bleeding. And it's, these things were either, never brought to attention or not taken seriously, so that it, like I said, it can take multiple generations for these things to come to light. Gum bleeding is a great thing to ask on taking a history. It's actually a pretty sensitive finding with more platelet disorders and von Willebrand disease. I also look at joint hyperlaxity. So what that means is, we focus a lot on all these different clotting factors in terms of bleeding and bleeding risk, but we have to remember that this clot is designed to attach to connective tissue and collagen. So even if everything is right with the coagulation system, well, what if something is abnormal with the collagen? And these are things that are very difficult to diagnose. We have a few rare diseases like Ehlers-Danlos that, there's some, genetic testing for, but there's a lot of these that don't have a formal diagnosis, but yet can still play a role both in joint health, which I know our physical therapist Laura talked a lot about, as well as bleeding symptoms. And then always, of course, don't forget to screen for iron deficiency anemia. Now, in terms of treatment, we have a few options. We have hormonal. This is good because it can be used for heavy menstrual bleeding, regardless of your bleeding disorder and even without a diagnosis of bleeding disorder. We do have to recognize the stigma of birth control, in fact, which is why I don't like to call it birth control. I actually say hormonal therapy, which is essentially birth control, but we're using it for hormonal reasons, especially in the adolescent population when mom's freaked out, like, oh, birth control, no, we're not ready for that. Think about it as hormonal control. And that's really what we're doing, both in changing the lining as well as some diseases like von Willebrand disorder. The estrogen in some of these options actually increases the level of von Willebrand factor, which can bring someone to a higher factor level and help them more globally with their bleeding disorder, which is key for any providers out there. Please, please, please test for von Willebrand before putting someone on any kind of estrogen birth control. There are non-hormonal options. A lot of the medical non-hormonal options are going to be those that are more specific to a bleeding disorder. There are different procedures offered by gynecologists, which is why I think it's very important that our obstetrician gynecology fellows be a part of HTCs and be a part of our bleeding clinics. Because our patients overlap and we're going to share issues and work closely with them. A lot of these, though, are limited to adults. Many of these, at least to some degree, will impact risk on future fertility. So, which is why I don't have as much experience with these in our adolescent population. And there's also practical considerations. Even if, a medication isn't right or medication isn't enough, we can still offer different things to help, how can we help your day-to-day life? Some of these period products that I mentioned, they are sort of newer concepts in the culture, and they may not be aware of them, and there may be things that can help them. So in regards to our hormonal treatment, again, let's do a little myth busting. So the first thing I see is adolescents especially, but women in general, aren't even offered the full breadth of options. And there's an assumption of what people are interested in and what people will want that is not always the truth. And even if, you were, correct about their preferences, well, maybe it's because they just didn't know anything about it. And over time, it may prompt them to go learn and think more about it. And it's something they may want in the future, but they'll never want that if they never know about it. The other thing is, again, focusing on it being birth control, that birth control is only for people who are sexually active. So that's why I call it hormone therapy. I do not subscribe to the idea that putting an adolescent on birth control will suddenly make them go start having sex everywhere. However, many adolescents are sexually active. If in the adult population, certainly young adults are sexually active. So I think it's very important to make sure that we remember that it is not a replacement for condoms. So still have that safe sex talk. There's also, I would call this a myth that you can't use birth control if you have a clotting risk. And I would say this is really where shared decision-making comes in. Yes, there is risk associated with these. However, I think this mentality devalues the impact that these symptoms have on women's lives, and the improvement in their life from taking a hormonal regulation for their periods, for them, it may be worth the risk. And I think that's the patient's decision to make. And I think if we're dealing with the clotting risk, for instance, factor V Leiden, that is does promote a fairly worrying risk of thrombosis, well, how can I safely help them do that? Maybe we do birth control and anticoagulation, some combination of therapy here. So, and I think instead of saying absolute no and not even going there, we really need to explore, why, how's this going to benefit you? Think outside the box, or the ways we can make this safe. The other thing that I really, really, really want to educate women on is that you don't have to have a period every month. This is the thing that women are not even told this is a thing. So it's not medically necessary to have a period. There's no additional risk to suppressing menstrual cycles. For instance, if you take birth control to have a period every month versus taking birth control to have fewer periods, it's the same risk. There's no additional risk. The other myth that I have to bust with a lot of patients is that by not having a period, your endometrial lining is not continuing to build up. So I think it's important to educate patients on why this works. So if you look at the different hormones that go up and down during your menstrual cycle, that proliferation phase that I talked about is in a setting of high estrogen and low progesterone. However, the birth control more mimics the hormone balance that's present during after ovulation, which is more of a stabilization period. So if you're on birth control, you never have this proliferation phase. So all you have is this phase right here, which is a little bit of growth, but more stabilization, which is why people on birth control have lighter periods. Our classic option is our combined oral contraceptive, or the pill. There's a million different options here. And I know for a lot of providers, especially non-OBGYN providers, there's so many options, it's very overwhelming. So there's really two decisions you have to make when you're deciding on an oral contraceptive. One is the dose of estrogen. The higher the estrogen, the less risk of bleeding. For someone with a diagnosed bleeding disorder, you really don't want to go lower than 20 micrograms. I typically go to the higher end because, again, these we can talk about what's best, what's high risk, what's the most efficacious, but every woman is different. And these are great starting places, but it may not be the right choice for everyone. Someone may have bleeding to something that most people don't, and you try something else. So I really want to try to make sure that the first one, we have the best chance of success. Otherwise, that can lead to a lot of discouragement and lack of thinking we can try other things. So I like to start off high, and then if you are concerned about side effects, then taper down after we've gotten things under control. The other question you have to answer is the type of progestin. In general, there's not a huge difference in a lot of them, but the ones that are most known for stabilizing the endometrium that we lean towards with heavy menstrual cycles is the levonorgestrel and norgestimate. The other things stick with monophasic. So there are some that kind of try to replicate the hormone up and down during the cycle. There's no proven benefit, and it doesn't allow you to manipulate the packs at all, which I will talk about in a minute. So when I said you don't need a period, what I'm referring to is what we call extended cycle. So the classic extended cycle is a 91-day cycle, meaning you have a period every 3 months or 4 periods a year. This is especially beneficial for women whose bleeding is significant enough that they have iron deficiency anemia. Sometimes we need to stop the periods for a while so that we can build the iron back up and not just keep losing it every month with periods. You can do it with any monophasic pack. You take 21 active pills, you get to the placebo, you just move to the next package. And then you take the placebo or skip it on the 12th week. In practical terms, what this looks like is 4 packs equals your 91 days. So what I tell girls is, if you're like me, I'm not going to remember which pack am I on? Is this 2 or 3? So what I say is, when you get to the placebo, have a little corner, a little drawer somewhere where you keep it, put it in your little spot. Next month, do the same thing. When you get to that 4th packet, we're at 4, skip a week, throw them away, start over. For providers, make sure you in the prescription, you dispense 2 packs so they have enough to get through the month. There are actually 91-day packs out there where 1 package gives you the full 91 days. There's fewer options for estrogen dose and progesterone, but they are out there and are very convenient. The other way you can do it is continuous, meaning the goal is to have no periods at all. I tend to find that the longer you go without a period, the more likely you have breakthrough bleeding. So it's really patient preference. If they don't mind some breakthrough bleeding and some unpredictability, great, versus, hey, I want to have 4 predictable periods a year. And then, by menstrually signaled, that means when you have the breakthrough bleeding, then you skip it for 4 days, have a withdrawal bleed, restart. There are non-oral options for combined hormonal contraceptives, so your estrogen and progestin. The classic one is the NuvaRing. This one, it will attain similar blood levels of the hormones, so you're going to have very similar efficacy and similar side effect profile to the oral. You can also do extended or continuous cycle with it. Typically, you leave it in for 3 weeks, have 1 week without it. However, continuous cycle, you just leave it in for the 4th week and then change it. Especially for first-time users, it can be helpful to know that you can ask for it to be dispensed with an applicator so they can insert it like a tampon. And I think these are things that are important to explain to patients when you're going over these options, because it may be a wonderful option for them, but there's we kind of don't know, like, now, how do you put it in? This seems weird. I don't know. So going over that can help them, feel more comfortable with some of these options. The other one is the patch. I tend to lean away from this one. There's some information out there that you may be getting higher levels of estrogen with compared to the oral equivalent. There was actually an initial one that was taken off the market because of high thrombosis risk, especially when you're doing it with extended cycle. So I don't tend to use this one as much, but it is out there. The other realm of hormonal treatment is progestin only. So we worry about those estrogen side effects. Well, we don't need it. Actually, the one that has the most data for being the most efficacious with the least side effects is the IUD. Most women become amenorrheic. Now, especially in my adolescent population, these girls aren't even told that it's an option. And yes, not many want to go there. Most look at me like I am an alien with 10 heads when I tell them what this is and what happens. But again, it's about education and exposure, and it's something they know is out there, and maybe can Google and talk to other people and learn about. And a couple of myths: it can be used in nulliparous women, and it does not increase the risk of PID. And these are important things to know, because I've had women come from a GYN who would not put this in for these reasons. And this is, old data, old thoughts when they first come out that the data has shown is not true. However, this is another thing that I really want women to be empowered to advocate for themselves, advocate for pain management. It's not something that is thought of enough. And so you have to be honest about, explaining how is this going to be put in, what's the experience like, and telling them what to expect, what to advocate for. The other progestin options, the Nexplanon, the implant, don't typically recommend this one, has the highest rates of breakthrough bleeding. The depot shot, this is the long acting that a lot of my adolescents choose. It's very convenient, does have some more progestin type side effects that some people don't like. The mini pill is one that I don't typically use because there's a lot, it's a lot less forgiving with missed or late doses. And so, which with adolescents is just a no-go. But if you do use it, know that you need, for heavy menstrual bleeding, actually much higher doses than the traditional one that's offered for birth control. There is one population, though, that this is actually the go-to. And that's for our transgender population. This here is just sort of a little public service announcement, making sure that we all understand what we're talking about with various terms. But I think the important thing to understand here is that this is different than gender expression. So, are they dressed like a man or a woman? Different than sexual orientation, and is different than transition, meaning someone may identify as a male, but be born female, and maybe they haven't or aren't going to go through the surgery or various hormone treatments, meaning they may have bleeding issues similar to what we think of as cis women. And again, important to ask, what do you go by? What pronoun do you prefer? And use that in our charting as well. So for trans men or non-binary people who have periods, they may want to avoid the extra estrogen. Now, if they are undergoing hormone replacement therapy, then those typically are enough to suppress the period. But if they're not, or have not yet done that, then yes, an IUD is an option, but the Endocrine Society actually puts first-line therapy for menstrual suppression as the norethindrone pill. So for someone who has bleeding issues as well, this would be where I would start. And again, we can't make assumptions about what people want and need. Someone may be dealing with periods, and it may be quite some time before they don't have to deal with that again. So we really have to sort of shift our thinking here. On the flip side, for trans women, it's more of clotting stuff we worry about rather than bleeding stuff. Our non-hormonal options, our First line is our antifibrinolytics, so Listida. Again, this is great because it's FDA approved for heavy bleeding with or without a diagnosis of a bleeding disorder. We have factor replacement if you have an known factor deficiency. Stymate is a classic one for von Willebrand before the recall. Ibuprofen is one I'd like to mention. We typically tell people with bleeding disorders you can't use NSAIDs. However, again, instead of saying can't, I like to say, okay, this is the risk. You decide, what's right for you. There are some women who have a lot of pain, and ibuprofen is all that will help them. Also, interestingly, in a lot of the gynecology literature about heavy menstrual bleeding and the treatment, ibuprofen is actually a treatment. It influences the prostaglandins in the uterine area that can actually decrease bleeding. So it's a bit of a plus or minus. So it's more of a, hey, these are the risks. This is what it might do. Just be aware of it if you decide to take it. Again, non-hormonal options, GYN procedures. The most common anatomical reason for heavy bleeding is fibroids. Endometrial ablation is a great option for if you want to avoid a hysterectomy. Again, we have can have impact on fertility, so not an option for everybody. And again, there's also practical considerations, beyond just the medical things. Are there other things we can educate on and offer that can improve their quality of life? So our take-home points is, having a similar index of suspicion for bleeding disorders, regardless of gender, really understanding the impact on quality of life, educate, educate, educate. And I'd like to leave you with one last quote, again, from that great article I quoted earlier. Knowing the von Willebrand disease or hemophilia subtype of the patient will be crucial to adapt treatment, but should not represent a limit in our perception and appreciation of disease severity. There are patients who experience major bleeds, some who have frequent minor bleeds, and our challenge is to address the different needs of the bleeders. The end. Any questions? I don't know if anyone's put anything in the chat. I can't see the chat while I'm sharing my screen.
Hey, Charlene, did y'all finish up?
Yeah, just did.
Okay, perfect. So I'm gonna go to the other room and stop the recording. And for anyone who is in this room, if you'd like to, you can bottom right, hit the leave room button and head back to the main room. And thank you very much, Dr. Davis.
Thanks.